So the time to start and three, two, one, and start.
Hi, I am Dr. Khan, one of the doctor in this medical clinic. Are you Mrs. Kathy?
Yes, Dr. M. Kathy, and I am 34 years of age.
Nice to meet you, Mrs. Kathy. Uh,
Nice to meet you, Doctor.
Mrs. Kathy, I am here to discuss with you your medical condition, and I would like to examine you, and then we can address your concerns. Is that fine with you?
Yeah, that's quite fine. Thank you very much, Doctor.
My pleasure. So, Mrs. Kathy, I have learned that you are having some fatigue. Is that correct?
Yes, Doctor. From last 6 months, it started, and it started quite gradually, Doctor, but it's getting bad. That is why I'm here now.
Oh, I'm so sorry to hear that. I will try my best to sort it out. Mrs. Kathy, you mentioned that this fatigue started gradually. Can you tell me, is this fatigue can you describe the fatigue? How does it feel like?
Yeah, I feel like my arms, they get tired, Doctor, and get weak.
Okay, and is there anything that is you have noticed that is making the weak this arms to get fatigued?
Yes, when I move them, when I do some activities, then
Okay. Okay. Mrs. Kathy, is there any particular time of the day in which the weakness is it is worse?
yes, in the evenings.
Okay. And apart from your hands, have you noticed weakness elsewhere?
No, it's in the arms. No, otherwise it's fine.
Okay. And have you noticed any problems with your eyes at all?
Yes, doctor. I think that my eyes, they get droopy in the evenings.
Okay. And have you noticed any double vision at all?
Yes, in the evenings I do feel double. I see double.
Oh, okay. Okay. And is anything that is making these weaknesses better?
When I take some rest, doctor, then I feel quite better.
Uh, Mrs. Kathy, I would be asking some questions regarding your general health. Kindly bear with me. Um,
Uh,
uh, have you noticed any problem with your breathing?
no,
And have you noticed any cough?
no,
Okay. And have you noticed any racing or pacing of your heart?
no,
Okay. And have you noticed any weight changes at all?
no. My weight has been stable, doctor.
Okay. And have you noticed any problems with your swallowing?
No,
Okay. And have you noticed that you are getting more pale than before?
no, I'm not getting pale.
Okay. And are you finding combing your hair difficult?
Yes, doctor, because in the evenings, especially, my arms get weak and weak, and I have difficulty.
Okay. And have you noticed any problem climbing stairs?
No, my thighs are fine. My legs are fine.
Your legs are fine. Okay. And have you noticed any lumps or bumps anywhere in your body?
No,
Okay. Mrs. Kathy, going back to your symptoms, the original symptoms, were there any prior episodes like this?
no, this is the first time, doctor, I got this problem.
Okay. And Mrs. Kathy, have you noticed any temperature preferences?
No, I like all the weathers, doctor. There's no temperature preference.
Okay. And have you noticed any pain in your tummy at all?
No,
And how are your bowels?
yes, my bowels are fine.
Okay. And have you noticed any problem with your urine at all?
No, my water works are also fine.
Okay. Okay. Mrs. Kathy, I would like to ask something about your past medical history. Were you hospitalized for any reason before?
No, no, doctor. Yes, about 5 years ago, I got very bad chest infection. Then I needed hospital admission for 5 days, otherwise never.
Okay. Okay. And did you have any surgeries before?
No,
Okay. And are you allergic to any medicine?
no,
Are you currently on any treatment?
no,
And are you taking any medicines over the counter?
No, doctor, I'm not using any medicine, doctor.
Okay. And Mrs. Kathy, is there any illness that run in your family?
Yes, doctor, my mother, she had rheumatoid arthritis and she had bad pain in the joints.
Oh, I'm so sorry to hear that. And Mrs. Kathy, are you taking any birth control pills currently?
Yes, doctor, I am taking birth control pills.
Okay. And okay. And when was your last period?
Last month,
Okay. And by any chance, are you preparing for pregnancy?
no, doctor, not yet. No.
Okay. And Mrs. Kathy, I will be asking something about your lifestyle. Kindly bear with me. Are you currently holding
Yeah.
any job?
Yes, doctor, I'm a teacher.
Okay. And how is this job affecting your life?
It's affecting me too much, doctor, because I see double whenever I read or I use my laptop for a while, for some time. I get some double vision and blurred vision, and then I have to take rest. And when I get ready, my arms get tired in the morning. So yeah, it is affecting me a lot.
Oh, I'm so sorry to hear that. I will try my best to sort it out. And
Mhm.
Mrs. Kathy, are you driving a car?
Yes, I drive my own car.
So, Mrs. Kathy, as you are having these symptoms currently, I would advise you to stop driving for the time being till the symptoms they
Mm.
get settled.
Okay, doctor.
And have you ever smoked?
Yes, I do smoke about couple of five cigarettes per day.
And have you ever thought about quitting smoking?
No, doctor, honestly.
So, Mrs. Kathy, like smoking, it can cause a host of harmful effects to your health. Okay, and if you want, we
Mhm.
can enroll you in a smoking cessation clinic. They will really help you out.
Yeah, that would be fine. Thank you.
And Mrs. Kathy, do you drink alcohol?
Yes, I do drink about 10 units per week, doctor.
Okay, that's fine. That's so, Mrs. Kathy, I would like to examine you now. Have you got any pain anywhere in your body at all? Any sore
No,
areas in your body?
no,
Okay.
no.
So, okay, so on general look, the patient is having bilateral ptosis. Okay, so I would
Yeah.
like to I would like to check the fatigability by asking the patient to look upwards to my finger and ask her to count till 20. So in this way, I will look for any slurring of speech,
Yeah.
any nasal twang to the speech, any worsening of
Mhm.
the ptosis.
Hmm. What else
And
you wanna?
I would like to look at the H shape and I shape in front of the eyes to look for eye movements
Hmm.
and any fatigability in that. Okay, one of the eyes I will lift up the lid. I will lift up. I will see the drooping in the other eye. Okay,
Very good. Yeah.
then I will check for any weakness in the neck muscles, neck extension, neck flexion, and
Hmm.
any weakness in the sternocleidomastoid. Then I will
Hmm.
check for the patient's shoulder abduction, and I would like to do the wing beating for 10 rounds. And then I will check the
That
power
would be
again
that would be positive.
okay, then I will quickly check for reflexes because reflexes are normal in myasthenia gravis. Then I will check for sensation because they're also normal.
But
Then I will ask.
the reflexes will diminish if you will check them multiple times.
Yes. So I will like to look for the proximal myopathy in the arm, in the legs. Also, I will ask the patient to cross their hand and to walk. Okay. Then I
That's
will
fine.
quickly auscultate the chest. Okay. I will have a look at the thyroid gland if there is any swelling. Okay. And then I
Hmm.
will like to percuss the chest in the midline to know for any thymoma.
Hmm. That's fine.
Okay.
No, there's no
And
thymectomy scar or thymoma.
okay, quickly look at the eyes for any anemia.
No.
Okay. So, so Mrs. Kathy, have you got any concerns?
Do I need hospital admission, doctor?
Mrs. Kathy, yes, you need hospital admission because we need to do some blood test and some test of your nerves also. So it's better that we will keep you for a short stay to make sure everything is fine. Yes.
That's fine.
Mrs. Kathy, have you got any concerns?
So is this, no, no, that's fine. I have no other concern, doctor.
So, Mrs. Kathy, I would like to explain you what you are having and what are my thought process. Okay. So,
Mm-hmm.
Mrs. Kathy, I am concerned that you might be having a condition. It is called as myasthenia gravis. Okay. We will be doing some nerve test and some blood test to confirm it. Okay. So it is basically a disease in which the body defense system, it is instead of fighting the bugs, it is fighting against the nerves and muscles. Okay. The connection between nerves and muscles in your body. Okay. And it can cause the
Hmm.
symptoms that you are having currently. Okay. So we would be
Okay.
doing our test to make sure your breathing is currently stable. Okay. So if that test comes out to be normal, then we can send you home.
That's fine.
Okay. Any other concerns you might be having?
2 minutes left. No, doctor.
Okay. And also, Mrs. Kathy, your pregnancy, if you are planning for it, it should be planned. Okay. Because the
Okay, doctor,
woman
I will take
doctor,
care
they
of
need
that.
to monitor your condition.
Okay, doctor. Okay, doctor, that will be fine. So I think we can stop here. We have time left, but no problem. So it was a good performance. You have 1 minute and 30 seconds left. So, my dear colleagues, whenever you finish early in the exams, say thank you very much for your time. I will now go and arrange some labs for you. Then I will be back for further management plan or discussion, whatever you think appropriate. Yes, so doctor, yes, well done. You tried your best. So, what do you think? What is the diagnosis and what is the DD for this scenario?
The patient is having myasthenia gravis. The differential would include other neuromuscular muscle junction disorders like Lambert-Eaton myasthenic syndrome. Um, uh, and the other possibilities could include uh, botulism, um, GBS, as they have this eye involvement, but they would be lower down the list.
And how are you going to investigate and manage this lady having myasthenia
So,
gravis?
so I would like to send anti-acetylcholine receptor antibodies. I would like to do a nerve conduction test with electromyography. I will like to also order anti-musk antibodies. I would like to do a chest X-ray and probably proceed to CT scan to rule out any thymoma. And I would like to do a force vital capacity to rule out any respiratory involvement.
Yes, you're right, very right. Management.
So management would include so management would include would include anti as would include acetylcholine esterase inhibitors like pyridostigmine. In acute cases, we will need to give patients IV steroids or plasmapheresis and and uh, 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 and watch for any respiratory depression by serial force vital capacity. And uh, 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 yes, this
That's
is the
fine.
main manager.
Yeah, that's fine. You're very right. So yes, and you the
And
top.
removal of the thymoma. Removal of the thymoma. Yes.
Yes, you're right. So well done. You tried your best, and it was a good performance overall. So let us now score it and see what we can improve in this scenario. As usual. Thank you very much. Now you can relax, and we will have a scoring of it. The mark sheet. Whenever you perform any case with you, with your colleagues, with anyone, the mark sheet should serve as a Bible for us. I mean, we should always keep it in front of our eyes because we need to pass every individual skill. So in the clinical communication, I suggest we can improve few things. You asked a lot of questions. That was a good thing. You ruled out breathing issue, you ruled out swallowing issue, but we can add on few more questions that would be helpful. In the physical examination, you did quite well. You check for the breathing, and you check for the legs, and you check for the thymoma. Fine. Okay, I will tell you a few more signs you can add on. DD is fine. Concern, I think we can improve a bit. This lady does not need admission, my dear colleagues. Remember, admission is a very sensitive thing, and you and we should not scare, or I should say, over scare the patient unnecessarily. Okay, so if this lady has no breathing problem at this moment, they have given the vitals, I guess, and you will also assess her during your examination. No need to tell her that I will keep you in the hospital. No. Suppose there are two candidates, one who admits they give this case, this simple, this not crisis, the simple myasthenia gravis. So they give this same case to two candidates. One admits and says, okay, you will need admission. And second says, no, you have no breathing problem now at this moment. You can go home. So what do you think? Whose judgment is better? So this lady does not need admission. Our colleague tried to correct himself later, but please remember, so in the concern and the judgment, you need to focus a bit more. Welfare is fine. Time management was very good. You finished well in time. So overall, there were two things in the judgment. One was driving. You stopped the patient to drive. Other was admission, which was unnecessary. So no need to scare the patient unnecessarily. Okay, please be careful. Admission is a very sensitive thing. Anyhow, overall a good performance. Thank you very much. And now, as usual, we'll have some discussion on the topic. So the lady presented to us with fatigue, and she is 34 years of age. Hopefully, when you will see the case, you will enter the station, you'll find this typical face, bilateral tosses. When you see this sort of picture or face in exam, either you think of myotonic dystrophy or you think of myasthenia gravis. Exceptions can happen, fine. But hopefully, when you will see this tosses, you will automatically somehow think about myasthenia, but still, you need to ask or analyze the presenting complaint. As I always suggest, there is no compromise on presenting complaint. Presenting complaint is the soul of the scenario. So these are the typical questions we ask for every presenting complaint. The onset, duration, progression, aggravating and relieving factors. But my dear colleagues, I suggest three extra questions when you get fatigue in exams. These are the routine OD para, onset, duration, progression, aggravating and relieving factors, but three additional questions when you suspect have fatigue in exams. What are those three questions? Number one, what do you mean by fatigue actually? You mean, and give examples of the patient. You mean you get tired, you get exhausted, you feel lack of energy, you feel low mood. Patients can perceive many things as fatigue, low mood, depression, weakness. Here we want to hear the word weakness. Fatigue, here, weakness will be more appropriate uh, explanation of this fatigue. Number two, is this fatigue in the whole body or in a specific part of the body? Fine. Number three, fatigue in any specific part of the day. Diurnal variation, more in the morning, more in the evening. Okay. So these three questions are a bit additional questions other than the routine questions, onset, duration, progression, aggravating and relieving factors. But then remember, you have to analyze the pathological complaint in a well manner. But hopefully, when you will see this lady having tosses and fatigue, and she will give you history of this fatigue in a specific arms or legs or wherever, and this has diurnal variation, then it becomes myasthenia. Now, as I always suggest, when you are done with the presenting complaint, analyze the system or the systems associated with the presenting complaint. In exam, generally we suggest in our routine clinical practice that we should analyze two systems in detail. Okay, thinking of the presenting complaint, at least two systems. But in exam, there is less time. So if you can analyze only one system in detail, that would be enough. So when you are done with the presenting complaint, you have to analyze the system associated with the presenting complaint. So with fatigue, generally, we suggest that you ask about constitutional symptoms or general symptoms. Fine. But since this scenario is very typically like myasthenia related to CNS, so it would be more appropriate to ask about the CNS questions in detail, like problem with memory, mood, consciousness, problem in sense of smell, taste, hearing, touch, headaches, headache, trembling, tremors, numbness, tingling, stiffness, shakiness of the arms or legs, any difficulty in walking, balance problem, difficulty in controlling your water works or bowel works, like this. Okay, at least one system in detail you must analyze, and that should be the system associated with the presenting complaint, my dear colleagues. Now, if you get a diagnosis, I mean, if you are lucky to comprehend, understand the presenting complaint, and you get a clue that this could be myasthenia, considering the fatigue worsens in the evenings, considering the fatigue gets better with rest, and it's only and the process. Then you have to do typically, I must say, three things in the scenario. First is definitely you have to rule out other symptoms of myasthenia. Patients can give you many symptoms like you can ask them drooping in the eyelids, difficulty swallowing, sleep, a speech issue, blurred vision, double vision, difficulty in climbing the stairs, change in your facial expression. These patients can claim that they themselves feel or their partners feel that they look gloomy or depressed in the evenings, difficulty in solving. So, you see, all these symptoms will automatically be ruled out if you ask about the CNS in detail. That is why I suggest please make it a habit to analyze at least one system in detail, and that should be the system associated with the presenting complaint. Okay. The second thing you have to rule out, and that is the very sort of uh, backbone of the scenario, is to rule out the myasthenic crisis. I mean, ask about breathing issue, ask about whistling sounds or breathing issue, shortness of breath. So remember, in myasthenia gravis, if the diaphragm is involved, you can have some orthopnea-like features if the diaphragm is involved, okay? But generally, shortness of breath will indicate myasthenic crisis, and that will be the indication to admit this patient. Only and only then you will admit. And third thing, you should remember, and that is a very basic thing, is to rule out Lambert-Eaton myasthenic syndrome. My dear colleagues, this is a very famous DD for myasthenia. So ask about autonomic involvement, okay? Ask about swallowing difficulty, speech problem. Do you feel dizzy on standing up? So rule out LEMS, Lambert-Eaton myasthenic syndrome. I hope when you will reach till this point, you will have no time. But if you still have time, remember one rule. that stands for every scenario. What is that rule? If you have one autoimmune disease, rule out other autoimmune diseases. Some things occur in clusters. Autoimmune diseases are one of them. So this lady has myasthenia gravis. Rule out some other common autoimmune diseases. You can ask about, are you getting pale? To rule out pernicious anemia or any yellowness in the eyes. To rule out autoimmune hepatitis. That things will fall in the systemic inquiry definitely. That's all. Remember one thing. This is fatigue, though this is not directly anemia. But remember, whenever you get a lady in childbearing age, you have to ask about three P's: the pills, the period, the pregnancy. This is very important in any case involving a young lady. And especially when you suspect myasthenia, you have to ask about the pills, the period, the pregnancy, uh, because of certain reasons. Because, the myasthenia gravis generally, um, overall, this is a general rule for every case involving the young ladies. Okay, but myasthenia has increased risk of congenital anomalies during the pregnancy, and myasthenia even can be worsened or triggered or unmasked in pregnancy or postpartum period. Okay, so this is very important. Three P's: the pills, period, and pregnancy. Other thing you need to remember when you're dealing with myasthenia case is medicine. Lot of medicines can cause or unmask myasthenia. Few on your screen you can see: aminoglycosides, streptomycin, macrolides, phenytoin, one of them. D-penicillamine, you can add on D-penicillamine. So these are very important things you need to remember. And I'd like to tell you one interesting point. Most of the drug-induced myasthenia is reversible, but the drug-induced myasthenia due to D-penicillamine may not reverse, because most of these drugs, they interfere with the acetylcholine esterase release. Okay, but actually D-penicillamine can sometimes trigger an autoimmune response against the receptors, so that may not reverse. Okay, anyhow, um, now the things will come for examination. On examination of myasthenia, remember, you have to do something in the face and neck, something you have to do in the hands and arms, and something, I should say, generally, uh, you can do something on the face and neck, something you need to do to elaborate the fatigability, number two. And number three, something you need to tell the examiner. Three things. And fourth thing is reflexes. So what you will do on the face and neck, um, in the face, for example, you will see for the ptosis, which was our lady already having, fine, okay, bilateral ptosis. Sometime this is not our patient, what I'm going to show you, but these pictures will help you to understand. Sometimes you can see this peak sign because there is um, ptosis, and there's a narrow like opening between the eyelids. Sometimes peak sign can be there. Sometimes you may find this thing. This is a very poorly controlled myasthenia. This is known as the frontalis overactivity. you can see persistent wrinkles in the forehead. Okay, persistent. And you will see continuously patient will be trying to uplift the upper eyelids because there is ptosis. So to overcome the ptosis, he will try to lift these eyelids up. So you'll find persistent wrinkling and activity in the frontalis, known as frontalis overactivity. This is not common, the jaw sporting sign. This was more common when there was no good medicine for the myasthenia, but nowadays we have very good medicine, so the jaw sporting sign is not common. But sometime in exams, when they are waiting for the candidates to come, this can happen because of the fatigue of the mandible. And you will ask then you will see the neck for this thymectomy scar or thymoma, thymectomy scar. Okay. So then one thing you'll ask the patient to smile. This is known as masthenic snarl. Snarl, I mean, is not a good word for, but fine. This is known as masthenic snarl traditionally. So you'll ask the patient to smile and you will never miss it. Very uncoordinated sort of smile. So something in the face and neck. Um, I think that's enough. Something to elaborate fatigability. If the ptosis is not visible on the eyelids, you can ask her to move the eyebrows, eyelids up, keep them open, and look at the ceiling. Don't bend your neck, okay? And gradually she will get ptosis. You can also ask her to raise the arms above the head. Gradually they'll fall down. You can also ask her to count from 1 to 100 in a single breath. So her voice will become husky and she will need to stop. So first time she stops at 50, ask her to do it again. Second time she'll stop at 40, maybe. She will get tired. Okay. The second thing you can do is this very famous, like we check the proximal myopathy. Check the power in one shoulder first, then ask her to move that shoulder up and down like 10 times, 15 times, then check power again. The shoulder which has been moved will be weaker. Okay. Similarly, you can also check the power or this fatigability in the lower limbs by asking her to stand up without support a couple of times, then gradually she will become tired. So third thing, reflexes. And the lower limb you can check, and when you will check the reflexes a couple of times, they will become diminished. This will be a distinguishing point because in Lambert-Eaton myasthenic syndrome, we expect the reflexes to become prominent as we repeatedly check them. What to tell the examiner? You will tell the examiner that I want to check for the the bedside vital capacity to check for the breathing. Okay. You'll tell the examiner that I want to check for the sitting and standing BP to rule out the postural drop because Lambert-Eaton myasthenic syndrome. And you will check the examiner that I want to do the ice pack test. I think I can show you the ice pack test. Now, myasthenia has a tendency to get better in cold environment, cold weather. So this ice pack test has now replaced the atrophonium or traditionally tensilon test. You can see in slide A there was ptosis in the left eyelid, and in slide B they put ice on that eye. In slide C, ptosis is gone. So you can do this you can offer the examiner, I want to do it, ice pack test. And a very famous question, what is the bedside test to diagnose myasthenia? Ice pack test. Okay. So something you will do in the face and neck. something you will do to elaborate fatigability, and something you will tell the examiner. No need to do all these fatigability tests. I mean, it will depend upon the pathetic complaint. Like in this scenario, the pathetic complaint was fatigue, and she told that her arms get tired. So you can do only in the arms and in the legs, one test in the legs, only enough. No need to elaborate fatigability in the voice and the breathing. Okay, no, there's no time, most of the time. DDs, well, the typical DD for myasthenia is Lambert-Eaton myasthenic syndrome. Okay, this is a very famous DD. Botulism can be a DD. Why not? And considering the age of the lady, we must rule out anemias, hypothyroidism. Considering the pathetic complaint is fatigue, we must tailor our DD according to the pathetic complaint, definitely. But this was myasthenia, so limited myasthenic syndrome, botulism, that will be fine. But you can say, I was also thinking about hypothyroidism and anemias, considering the lady age. Other is, I think, simple investigations and management. Typically, we do some tests for myasthenia. You can say we can do the serology, which will show you anticholinesterase antibodies, and electrophysiological studies you can do, which will like you can do the repetitive nerve stimulation test, which will show you decremental response. You can do single fiber electromyography. You can do CT to rule out thymoma, and you can do the routine investigations like autoimmune profile to rule out other autoimmune diseases. Management is simple, no need to admit. You will admit only and only when there is crisis. Otherwise, you won't admit. Okay? And usually we give them pyrosigmine, neosigmine, the anticholinesterase limiters. Um, Most of the time, the response is good. Sometimes immunosuppressants could be required, fine. And steroids, immunosuppressants can be given, and sometimes even steroid-sparing agents can be given. Very rarely, you can also try monoclonal antibodies. Um, in some patients, anticholinesterase antibodies will not be positive. Then you can do anti-mask antibodies. Please add on in the investigation. And yes, surgery should be offered for everyone having myasthenia. And usually they say that after 3 months of thymectomy, the symptoms of myasthenia start improving. Nowadays, they're also looking for some autologous stem cell transplantation studies going on. Hopefully, it will be fine in the future. Patient must stop driving. Actually, patients with myasthenia, they can drive with some measures, precautions, like they should wear sunglasses or they should have frequent pauses while they're driving. And when they start seeing double or blurred, they should stop driving immediately and take rest until their eyes are fine. But for exam purpose, I always suggest keep the thing simple. So refer this patient to DVLA. They will deal with her and tell her that she needs to stop driving or not, or when she can regain her driving. Okay. So this was the scenario. The last option you can see on your screen, plasmapheresis and IVIG is meant for myasthenia crisis, not for our scenario, but for crisis. For myasthenia crisis, you can have the patient plasmapheresis and IVIG. You can give them. Okay, so this was the scenario. Well done. Our colleague did quite well. Now we can take question. So there's one question in the chat about steroid dip. Well, basically the myasthenia has a tendency to get worsened when you initiate the steroids. I mean, when you start steroids, for a couple of weeks, myasthenia will be worsening. 1 or 2 weeks. This is known as paradoxical effect or steroid dip. So after that, a patient will start improving. So it is usually suggested that if unfortunately time comes when you think you need to give steroids, then you admit him in the hospital, then start steroids. Okay. So myasthenia has a tendency to get worse during when you start steroids. So when you are planning to start steroid, admit her, then start steroids. Driving in myasthenia contraindicated. Refer this lady to the DVLA. They will guide her what to do next. Simple. Remain simple. Driving in myasthenia contraindicated. Stop her to drive and refer her to DVLA. They will tell her what to do next. This is not our job. Keep the thing simple. Okay, Lord? Any other question? Or anyone has got this scenario in his or her exam, a typical exam scenario, and wants to share the experience with us? No. Then thank you very much for joining, and hopefully we'll continue. Next week we will do some communication scenario. Thank you for joining. Enjoy your weekend. Bye bye.